Anyway, I'm Henry Swoboda. I'm emergency medicine trained. I did a medical toxicology fellowship with focus on addiction medicine. And now I'm doing toxicology consults here, as well as I'm the attending on the inpatient substance use consult service, which really just started seeing patients in November. So we're pretty new, but looking to expand all sorts of addiction treatment here in the hospital. And I think part of that can be kind of helping facilitate use of some drugs like buprenorphine by the rest of the medical staff. So,
is it just you on the consult team, or do you have a support staff?
yeah, so on the team, on the inpatient team, there's a social worker, Elizabeth. And then there's going to be 2 nurse practitioners. Currently, there's one, Katie Perticone, who's also the psych, NP as well. And so they're gonna split it. 1 week Katie will be on, the next week Megan will be on once she's onboarded. We also have a clinical pharmacist who's helping as well, and then we have some outpatient staff who may get involved with some of it as well because they have a clinic then.
Is it the suit
as well?
team?
Yes,
Oh,
yeah, that's what we are.
So Colin would use most?
So kind of tangentially. So the Collins with the kind of complex care team, and a lot of times we share patients, with that. So he, and like when Elizabeth, she has other responsibilities as well. So if she's not able to care for a patient or whatever, usually Colin or Carrie step in with that as well. Yeah. So I was going to get started and talk just a little bit about the opioid crisis in general, just to kind of give a little bit of background, talk about the different options we have out there for medication-assisted treatment. We'll talk about some of the regulations, because you guys may kind of worry, I can't give methadone, can I give buprenorphine, what are the rules? You guys probably don't have X waivers, so we'll talk about that a little bit. And we'll talk a little bit about buprenorphine, just the basic pharmacology of it, because it's important, because it's different from some of the other drugs that we use. It's different from just a standard opioid, and so that's why I'm here. So we'll talk a little bit about the rationale for why it might be good to use it on an inpatient basis, and kind of how we would get patients started on it in the hospital. So just briefly, I'll try and refer to patients as patients who have a substance use disorder when I'm talking here. There's some data that shows that referring to patients, giving the same vignette about a patient who's had positive drug tests and is going to court, that by referring to them as a substance abuser, people who read the vignette are more likely to go for kind of punitive measures as compared to pursuing like a medical model of disease sort of approach. So we like to refer to patients as patients who have a substance use disorder, which is it's a DSM diagnosis. There's all sorts of criteria for it. I probably qualify for caffeine use disorder, or I have tolerance, withdrawal, cravings, use despite medical side effects like insomnia. So, but that would qualify as a mild or moderate disorder. Most of our patients we're talking about have a severe substance use disorder and impact their social and functioning.
Would you recommend putting that in the note, like in our medical notes, substance use disorder rather than substance abuse?
Yeah, I mean,
they're pulled for whatever medical legal issues.
I mean,
or does it probably does not matter?
I don't think it matters. I mean, I think it's kind of important just to kind of change the way that we think about it. It can be helpful, but as far as kind of medical legally, I don't think. I mean, it is an actual, it's like I said, it's a DSM diagnosis. It has ICD codes and stuff. So substance use disorder has a definition, which, we can, so it can be a little more accurate to describe it as that way. You guys might be familiar, or maybe not, with kind of one of the studies that kind of kicked off the whole opioid crisis. It's probably a little much to refer to it as a study, is this Porter and Jick quote-unquote paper. It's 1 paragraph long, just basically a data mining project of 12,000 patients who got narcotics while in the hospital, and then seeing whether they later got a diagnosis of substance use. And they found that there was very few in people who got narcotics while in the hospital. Nothing about follow-up, and they weren't even really followed in a consistent way. It was just looking at diagnosis codes. But as we know, most of our patients don't get their substance use disorder. They don't become accustomed to using opioids in the hospital. We have some data that most patients or most people who have substance use disorder, this blue part is that they get their substances primarily free from a relative or friend who got the substance from one doctor. So it's our prescriptions for these opioids that can be the problem. And this is some data from a recent MMWR, just showing that the number of patients who have a 1 or 3 year probability, 1 year or 3 year, of being on opioids increases with the number of days of their first prescription. Now, there can be several factors you'd think about that. Someone who needs a 30-day prescription probably has more chronic pain disorder. So, it's not exactly causative. But I think it's fairly striking that if you end up writing someone for their first prescription based on an insurance database of opioids for 15 days, they have a 15% probability of being on those opioids 3 years from now. So it's just kind of worth considering and having a discussion with patients that's saying, I'm writing you for a week worth of medication. That actually means that you have a 7% chance of being on these medications in 3 years. So I want you to be careful with your use of them. And just here is some data looking at that Porter and Jick quote-unquote paper. The big green bars are basically positive mentions of the study as it was used to support the prescription of opioid medications for patients, saying, well, opioid use is not, opioids given by a doctor, they would say, is not associated with risk of substance use or substance abuse or substance use disorder. And it was cited all the time, put forward by Purdue Pharma, the makers of OxyContin, as a way of supporting it. It was cited over and over and over again as in this positive manner to say, our opioids are not addictive, so keep prescribing them. And you can see here is the 90s through the 2000s, and that's really where the prescriptions started taking off there. And just again, here we have the year 2000, and we have overdose deaths from any opioid going up from 2000 to 2015. And we can kind of see the evolution of the opioid epidemic, going from our commonly prescribed opioids, and then after people have been on those for quite a bit of time, we had our baseline level of heroin use start bumping up, and people are transitioning from their original opioids of choice to a heroin epidemic. And we start to see this little blip going from 2013 to 2015 for synthetic opioids, which if we pull the data out, here's that blip, and here we are, our synthetic opioids are accounting for 20,000 deaths each year. Now in 2016, for a total of 60,000 deaths in the United States each year. So there's a lot of patients, and these are drug overdose deaths. I mean, this isn't anywhere near the scope of the substance use disorder problem. These are the number of people who are dying each year from it. So it's clearly a huge problem that kind of addressing in the hospital is the first step in trying to link these patients, some of these patients, with care. Obviously, there are other factors involved with the evolution of the drug opioid epidemic, other than this Porter and Jick paper and OxyContin. There's the Joint Commission putting forth pain as a fifth vital sign and linking our jobs and reimbursements to patient satisfaction scores. All this stuff is kind of contributing to where we are now, but we still have to see where we're at and tackle it. If you're interested in the history of how we got to where we are, this book Dreamland is good. It describes both kind of the pill mill epidemic, the push by Purdue Pharma to push OxyContin and other opioid therapy, as well as the rise of heroin in the United States as well. So you want to get a picture of kind of the history behind all of it. This is actually a really great background. But where we are now, we have Tom Frieden here, the former director of the CDC, wrote in JAMA these 10 steps for the federal government to reverse the opioid addiction epidemic. And numbers 7 and 8 directly refer to increasing the availability of medication-assisted treatment, saying medication-assisted treatment should be routinely offered in primary care, emergency departments, and hospital inpatient services to increase patient treatment uptake, as well as in the criminal justice system, with careful attention to continuity on discharge. And we'll address some of that, because that can be a huge kind of leap for some of the patients, is to get them hooked up with treatment for discharge. But also to expand low threshold access to the opioid agonist treatment, particularly methadone and buprenorphine. So those are a couple of steps we're trying to take to treat the people who have the disorders already. So the options we have for medication-assisted treatment include a long-acting antagonist. So you guys all know naloxone. We use it if our patients are respiratory depression in the hospital. There's a long-acting injectable antagonist, naltrexone. It's a monthly injection, and it blocks opioids for a month. Having said that, it doesn't do much of anything for cravings. And a lot of times patients then will just not show up for their next shot if they're finding that they're relapsing and they're not having the effect that they want from it. And then there's a couple of other ones of opioid maintenance therapy where we have patients on drugs that stimulate the opioid receptors, namely methadone and buprenorphine. So the way we can kind of differentiate between these couple of compounds is methadone, as well as basically all the other opioids that we use in the hospital. There's a couple other ones, Nuvain that they use in OB a little bit more that are partial agonists. But for the most part, all the opioids we use, tramadol even, it's a full agonist. If you give more and more tramadol, eventually you're going to get, a maximal degree of opioid stimulation. Whereas once you reach this kind of ceiling effect for buprenorphine, it's what we call a partial agonist. So no matter how much more you give to a patient, they're only going to reach a certain effect for it. And then again, with the antagonists, no matter what you give on top of it, if you have enough naloxone on board, you can block them. Or I guess if the ratio of naloxone is high enough, because it can always be overcome with more opioid. So like I said, naltrexone is our blocker. It is also used for alcohol. We use it to decrease cravings for alcohol, but it doesn't seem to work quite as well for cravings for opioids. And so it's certainly an option for detoxed patients. We're working on getting it on formulary here. Basically, it'll only be used by the suit team for patients who have already been detoxed and need some kind of support for staying off of opioids. But for our opioid maintenance therapy, so getting people on these opioid agonists, the reasoning as it was described by Dole in like the 60s and the 70s was that he hypothesized that these patients have a metabolic disorder of the brain due to an absence of the opioids which they've become dependent on. Since then, our understanding of the science behind it, the mechanisms of tolerance and withdrawal have become more complex. But it's the main idea is that we're replacing the opioid with another one that can decrease the cravings. And so here we have early on, a patient uses their opioid to get euphoria up here in the green. Later on in the course of an addiction, the patient's really not becoming euphoric anymore. They're just trying to use their opioid to stave off withdrawal and keep in the normal range. And so then we assist them with medication with keeping their brain chemistry in the normal range, not with the goal of euphoria, but to keep them from having cravings. And medication-assisted therapy, the data is better for methadone because it's been around for much longer, but it's been shown to decrease IV drug use and relapse, which is obviously a large goal, but there's a lot of kind of harm reduction part of it as well. So decreased HIV, decreased criminality, decreased death, with improved health, employment, and social function. And so our goal for our patients is abstinence, but if that's not achievable, decreasing the rates of HIV and criminality, I think is a good goal, and then healthcare utilization, all that stuff is a good goal as well. And it's been shown to have some of those effects. I think the Cochrane review, based on the quality of the data, will say it decreases IV drug use and doesn't have as much to say about the rest of it. But that's because since, again, the 1960s and 70s, methadone has basically been the standard, and so it's been hard to justify in a randomized control trial to take patients who would otherwise want to be on methadone to randomize them to something else. Because for the reasons that we're seeing here is that patients who are detoxed, this Kaplan-Meier curve is patients who are randomized to methadone versus detox, and it was a randomized trial. They had placebo pills put in there. Everyone started with methadone, and then right around here they started tapering them off the methadone, and you see this is engagement with treatment. And all the data I was telling you about, it's all relating engagement with treatment to those positive health outcomes. And so as they start to taper, patients who are tapered off their methadone just uniformly stop engaging in treatment. And the same kind of data has been shown with buprenorphine. This is a very small study. There was only 20 patients. But again, the patients all were started on buprenorphine, and then kind of starting here at 0, they began a taper of the buprenorphine and put them on placebo. And by day 60, by 2 months, there were 0 patients engaged with treatment with placebo, even though they were getting psychosocial support for their opioid use disorder as part of their treatment. They weren't coming back anymore because they were having cravings and withdrawal and were having relapse. So regarding the legality of use of these medications in the hospital, here at RUH, we limit the ability of anyone but psychiatry to use methadone other than just kind of continuing it. Because it's a complex drug as well, there's a lot of dose stacking issues, and there are some legal issues with it. But in the end, the regulations say that we can use these drugs, methadone or buprenorphine, for use in the hospital. But the difference in how they're regulated in the outpatient setting is that methadone is specifically for an opioid treatment program, and that's the only way it can be used for an opioid use disorder. It can be used for pain in any physician's practice, but in these opioid treatment programs, these methadone maintenance programs, are highly regulated, how it can be used, how you can prescribe it, how you can give take-home doses, how you can increase it. And that was all delineated in the Narcotic Addict Treatment Act of 1974. Buprenorphine, on the other hand, is used in office-based treatment. And so that's why it's kind of a big deal when we're doing more and more of it, is because we can maintain these patients in a setting that's different from these highly regulated methadone maintenance programs, and so we can expand access to care through use in the office by primary care physicians, addiction specialists, psychiatrists, all sorts of providers. And so in order to prescribe it, you need something called an X waiver. It's just an addition to your DEA license that will allow you to prescribe the medication. You have to do an 8-hour training course and apply for an X waiver. And this was all delineated by the Drug Addiction Treatment Act of 2000, and then it was expanded to PAs and NPs by the Comprehensive Addiction and Recovery Act of 2016. So in the last 18 years or so, it's been made available for use in office-based practice. But if we want to use it in the hospital, as I said, any provider is allowed to use methadone or buprenorphine by law for a couple of different situations. And it's spelled out in Title 21 of the Code of Federal Regulations very clearly in the section on administering or dispensing narcotic drugs, that basically to treat withdrawal symptoms or to treat opioid use disorder that's secondary to another medical condition. So a patient is on opioids, they're injecting heroin, and now they come in because they have endocarditis. Well, their admission to the hospital is secondary to another medical condition, and thus they're in withdrawal, and we can use it for that. So the patient isn't presenting for opioid withdrawal, they're presenting for something else, and so we're allowed to dispense these medications in the hospital, administer or dispense. So you wouldn't be able to prescribe it for them as an outpatient, but you can administer or dispense it in the hospital for that purpose. Likewise, you actually can use it for primarily withdrawal. So a patient comes in unable to tolerate PO from their opioid withdrawal. We're allowed, even if you don't have an X waiver, so these are non-X waivered physicians, we're allowed to give it for primarily withdrawal with a 3-day limit. So you'd have to find an X-waivered physician to continue it beyond that point, but usually a patient comes in, and if their primary complaint is opioid withdrawal, you treat it with buprenorphine, and then you send them to like a detox or something like that, if that's how they want to link to care. Haymarket is always open, so I'm accepting detox patients, so if that's their only complaint, you can treat their symptoms, stabilize them medically, and get them to detox. And then again, for pain use, you can use it, the medications aren't really spelled out by these legal requirements. But as I said, for the withdrawal secondary to a medical problem, we can use it in the hospital throughout someone's stay. So in looking at kind of methadone versus buprenorphine, again, as I said, at RUH, we need psychiatry or the addiction team to help us write for methadone. But in general, buprenorphine is superior in a couple of ways to start with anyway. It has that ceiling effect, which again we'll talk about a little bit more. It's titratable in a more expedient fashion. So methadone, we have these dose stackings, and so really you shouldn't be increasing the dose more than every 4 or 5 days, having a dose increase, where we can really go up on the buprenorphine faster than that. We can prescribe it, as someone who has an X waiver can prescribe it to either get someone to a detox program in a couple of days, that sort of thing. There's usually less severe withdrawal, because with methadone you have this full agonist up here, but then you kind of start lower down with the partial agonist for buprenorphine. So it's been demonstrated to have less severe withdrawal, so just transitioning them from a full agonist to the partial agonist will ease their withdrawal symptoms, even if they just kind of go cold turkey from there. And then the use of buprenorphine doesn't preclude the use of methadone, whereas conversely, if someone is started on methadone, it's this long-acting drug that won't let us start someone on buprenorphine easily. There are minuses, though, to the use of buprenorphine in the hospital, is that in order to have an induction, in order to start buprenorphine, the patient does have to enter a degree of withdrawal, or not be dependent on opioids, but they need to be in withdrawal to start it. And if they're not in withdrawal, there is this risk of precipitated withdrawal, where basically it acts as an antagonist. It acts like naloxone if you give it to someone who is intoxicated. And then it can somewhat complicate analgesia for the patient. And we'll talk a little bit about that. But patients who require surgery can still receive surgery even if they took their daily buprenorphine dose. We can hold the dose if we need to, and we can actually give additional doses of buprenorphine if we have acute pain. So it doesn't, it complicates it, but it doesn't make it impossible. And here's just, again, demonstrating the difficulty with methadone. This is dose stacking over the course of a couple of days. Someone's on a steady dose, and yet we're dosing it more frequently than the half-life. And kind of a common story is out here, day 5, someone got started on 50 milligrams of methadone a day, and by day 5 they're found dead in their bedroom at home, because that's when you actually finally reach steady state for that. So it's a difficult drug to manage. That's why it's so highly regulated. It has a couple of other problems: drug-drug interactions, QT prolongation, the slow titration we talked about, and it is a full agonist, and so you have all of the side effects: respiratory depression, constipation, endocrine side effects that you'd have with other kind of full opioid agonists. Buprenorphine, like I said, is a partial agonist and will help us avoid some of those other difficulties with methadone. And so we'll kind of go over some of the specific interesting bits of the pharmacology of buprenorphine. So this is a little small, but I'll spell it out for you here. So the unique aspects of the buprenorphine pharmacology over here and how it affects our practice is on the other side. So up at the top, buprenorphine is a high affinity agonist. And so what that means is that it can cause opioid blockade, is that if we are giving kind of equianalgesic doses of buprenorphine and fentanyl, the buprenorphine is going to stay bound to the receptor because it has this high affinity for the receptor. And so what happens more commonly is that somebody comes in, they're on heroin, relatively low affinity, we give them the buprenorphine, and it knocks the heroin off the receptor, and they can go into precipitated withdrawal because, again, they go from this area where they have a full agonist, and now they're down in the zone of a partial agonist, and it's the sudden drop that worsens the withdrawal for them. It is this partial agonist. So again, there's a ceiling effect to how much opioid stimulation, opioid receptor stimulation you'll get from buprenorphine. You could, once someone is on around 16 milligrams, their opioid receptors are saturated, and you're not going to get more of an effect beyond that as compared to, again, fentanyl. You can titrate to respiratory depression without a problem. It has unusual pharmacokinetics, so there's a lot of first-pass metabolism with buprenorphine, and that's important because we administer it sublingually. And it's not like a Zofran where you're like, just hold it in your mouth till it kind of dissolves ODT style. I tell all my patients this is a sublingual medication. And especially with the tablets, which we have here, I tell them it can take up to 15 minutes to dissolve, and I want you to sit there for 15 minutes and not swallow your saliva. Some people will either swallow the pills, which is the worst. Others will just kind of swallow it as it dissolves, but you want them to leave it in their mouth and actually absorb it sublingually instead of from the GI tract because of this large amount of first-pass metabolism. You probably get about 3 times as much absorption sublingually as you do PO. You maybe get a 10% bioavailability PO and more like 30 to 50 sublingually. And then it has this long half-life and short analgesic duration, which is odd. So for addiction, we can prescribe buprenorphine daily, and it prevents withdrawal and can help with cravings. But for pain, we actually end up splitting the dosing of the buprenorphine. So as I said, this is just kind of demonstrating what we're talking about. It's got this high affinity for the opioid receptors. By the time the lighter colors here are available opioid receptors in the brain, and these are in heroin addicted patients. And that by the time you get to 16 milligrams, which is not an unusual dose for substance use disorder, you have basically no available opioid receptors in the brain. It's got this ceiling effect that we talked about. Here in the red is total apnea, respiratory depression. Down in the yellow is what they say is the amount of stimulation you get from one normal Vicodin tablet. in the blue is powerful hospital pain relief. And so we talk about buprenorphine as having a ceiling effect, thinking, well, if we really need an opioid, we can't use buprenorphine. We need it for pain or that sort of thing. And it's important to understand the ceiling effect because, again, if someone is living up here with their heroin, they get knocked down there to the buprenorphine, they will have withdrawal. But buprenorphine does live up in that zone of a powerful pain relief. You just can't titrate it all the way up to near apnea, which some of our patients prefer for their pain relief. And despite the ceiling effect, there still is the possibility of buprenorphine abuse. And so it's less the height of the agonism, but kind of the rapidity to which you get there. So patients will still snort or inject their buprenorphine, and hence it's mixed with naloxone. Naloxone is even less orally or sublingually bioavailable than buprenorphine. It's basically not bioavailable at all through that route. But if you inject it, then of course naloxone is bioavailable, and so that'll prevent patients from injecting it that way. The only patients where it actually comes up in about whether the naloxone component is a problem is pregnant patients, and there's some debate on it. But for the most part, we don't think of the naloxone as an active component in any way for our patients who are on it for maintenance therapy. And just to kind of talk about it a little more, it has these unusual pharmacokinetics. To reemphasize, this curve is actually for methadone, but it kind of demonstrates, again, for pain, remember we use methadone like 3 times a day, something like that, because it has this alpha redistribution over 8 hours, despite the fact that its actual beta elimination is more on the order of 2 days for its half-life. And the same thing is true for buprenorphine, that we use it daily for addiction, but if we're using it for pain, we're increasing the frequency of the dosing, not even necessarily the amount of the dosing. And so, in addition to just its pharmacokinetic issues, the partial agonism, it has some unique receptor effects as well. So we're so used to talking about mu agonism. That's what we're talking about when we're talking about opioids for just about everything else. And as I said, for the mu receptor, buprenorphine is a high affinity partial agonist. And the mu receptor mediates our analgesia, sedation, a lot of the side effects, and a lot of the euphoria as well. And so that's what we're targeting with a lot of our other opioid medications. And a lot of the other opioids are either mu and delta with a little bit of kappa in between, and some nociceptin, but they're agonists, full agonists at both kind of mu and delta. But what makes buprenorphine different is that it's a kappa antagonist. And there's some evidence that kappa antagonism is useful for its antidepressant action. And we do see some additional kind of mood stabilization effects of our patients who are on it, whether that's from decreased drug use, that sort of thing, or whether it's actually this kappa antagonism. And so kappa agonism is associated with dysphoria, psychosis, and a phenomenon called opioid-induced hyperalgesia, which, if you're not familiar with it, I think the best way to kind of understand it is kind of through its animal model, where they take mice or rats and they give them opioids for a number of days, and then initially they gave them a stimulus. They put their tail on a hot plate, and they measure the temperature at which the rat kind of flicks its tail. So that's measuring its pain threshold. So then they take the same rat who's been on morphine for 2 weeks, and they put them back on the hot plate, and they'll flick their tail off sooner. So they're experiencing pain, despite the fact that they're on morphine, they've been accommodated to morphine, they're experiencing pain at a lower stimulus. So our patients who are on chronic opioids are actually having an increased experience of pain due to the opioids that they're on. So it's not only tolerance and receptor internalization that's leading kind of to a decreased mu effect from the opioids, why they need escalating doses. They're actually experiencing more pain with their whatever stimulus they're having, and so that's why they're requiring increasing doses. But with the kappa antagonism, buprenorphine has less of that, and so patients are able to maintain a stable dose. Delta is also involved in intolerance, and buprenorphine is an antagonist there. And then there's also some effect at nociceptin, which is a partial agonist. It has some effect. If you give a full agonist for nociceptin, patients will actually have more pain not as important for the buprenorphine. If you have to remember what buprenorphine is, that it's at mu, it's this high affinity partial agonist that we talked about, and at kappa, it's an antagonist, which will decrease kind of opioid-induced hyperalgesia and provide some mood stabilization for our patients.
Buprenorphine for pain would still require an X waiver?
Yes. Yeah. And so, yeah, and I use it for that purpose for some of my patients, but they all have a co-occurring substance use disorder. So I have patients who, chronic back pain patients who then escalated their opioid use, we're getting early refills, perhaps buying some on the street, some transition to heroin. But it all started with their pain, who now are transitioning to buprenorphine, and we're using it both for pain and addiction purposes kind of simultaneously. And then so for drug-drug interactions with buprenorphine are few. I'm talking about them because this is a talk on buprenorphine, but just know that methadone, we're always worried about what are the drug-drug interactions with methadone. Someone's starting a new med. Are we worried about respiratory depression with the methadone? What's going on? Methadone is metabolized by CYP3A4, so is buprenorphine, but to a much less extent. And so the only drug that really has ever been shown to increase buprenorphine concentrations to a level that might increase, any sort of side effects is atazanavir. And otherwise, the other HIV medicines may be CYP3A4 modulators, inducers, or inhibitors, but they really have not had an effect. Again, because of the ceiling effect of the buprenorphine, you're just not going to get as much of an effect from there. The only real drug-drug interaction that we worry about is with other sedatives. While there is a ceiling effect on the opioid effect, if you start stacking benzodiazepines and anticholinergics, someone's getting 10 of Valium and 50 of hydroxyzine and their buprenorphine, which we run into with our patients who say are on a CEWA and a COWS protocol. Just remember that those combinations, despite the ceiling effect, can have respiratory depression, so your patients need to be on a monitor. And when we prescribe it, you can see this box down here basically says the FDA says that it's okay that our patients, a lot of our patients have co-occurring anxiety or aren't willing to be 100% absent from alcohol, so you just have to weigh the risk and benefit. So it can be co-prescribed with benzodiazepines. There's just a risk. But the way I always think about it is the risk is less than if someone is either injecting heroin or on full agonists, OxyContin or whatever, but we worry about death from OxyContin and benzodiazepines as well. So you just have to worry about it as well. You just don't stop worrying about it because of this ceiling effect.
Naloxone. If you say you got a bunch of different medications and you want to get that buprenorphine down, but it's got that high affinity, does naloxone, is it still effective? It's effective,
but there have been cases, I don't think there's, as far as I know, there's not data universally, but there's cases where people require very large amounts of the naloxone to reverse the buprenorphine. Like I saw, and it can happen in people like kids or other people who can have respiratory depression with just the buprenorphine. So there's certainly overdose cases in kids who then they have to get large doses. I've seen somebody needed to get finally like 14 milligrams of naloxone before they finally had a response to it. So it is a high affinity thing. So yeah, you need to keep pushing it to reverse it. Which is interesting because there's like 0.5 milligram in the it's 2 to 0.5 milligram for buprenorphine to naloxone in the tablet. So the naloxone isn't going to reverse the buprenorphine entirely. It just attenuates the rewarding properties of it. Again, people would inject buprenorphine for its kind of euphoric effect if they had pure buprenorphine. You add a little naloxone in there and it's just not as happy of a high, and so people don't do it as much. And so, yeah, so like I said, I mean, if you understand this graph with full agonists at the top, partial agonists in the middle, including buprenorphine, and antagonists at the bottom, you're all the way there to really being able to use it in the hospital. I've thrown a lot of other kind of information at you about why we use it and and how we use it, but that's kind of the thing that you have to remember is that buprenorphine will drop you down to precipitated withdrawal if they are on a full agonist, but by the time you're on methadone, by the time you're withdrawing back down this way, by the time you're here and you're in severe withdrawal, or if this is withdrawal from heroin, then you give them buprenorphine and it'll stabilize them. So yeah, that's why you wait till they're in withdrawal. and then you can hit them with a partial agonist to treat their withdrawal. We talked a little bit about the pluses and minuses. Now we can talk, a lot of what I talked about is a little more relevant to the clinic setting, so we can talk a little bit about its use in the hospital. So this is Liebschutz's paper. It was published, it was on 139 patients, I think it was 2015. They basically randomized patients to getting a buprenorphine detox versus linkage. And this was for patients presenting to the hospital for other medical complaints. That's a lot of the patient population that we're targeting here. And these are patients who, they didn't come to the hospital like ready to quit drugs or wanting to change or seeking out a treatment strategy. They came to the hospital for their cellulitis. And so it's a patient population that we're not expecting great drug treatment outcomes from because they're not exactly there yet. But they found that by starting people on buprenorphine in the hospital and linking them to ongoing prescriptions of it, that they were able to increase entry and persistence, so the patients were staying in treatment longer, and they were able to decrease 30-day drug use after these patients were hospitalized. And then, like I said, they discharged with a linkage prescription, 2-day prescription to get them to an appointment in the clinic, and then they'd be seen in the clinic and linked with psychosocial care and ongoing buprenorphine. There's similar results in a study in the ER for, again, patients who would present to the ER and have their buprenorphine started there. And so it can help our patients engage with treatment for sure. The question always comes up, well, the patient's here in the middle of the night, or they have bad insurance or no insurance. We don't know whether we're able to link this patient with care. I went over those couple of Kaplan-Meier curves just showing that detox is not a solution for addiction. It can be a first step, but patients who are just detox will relapse if they're not linked with some sort of care, whether that's an inpatient rehab, buprenorphine maintenance, something. But these detox patients will relapse if you just detox them in the hospital and discharge them after their COPD exacerbation has resolved. They'll be back using drugs very rapidly. The vast majority of them. Obviously, is it 100% no? But I think the vast majority of patients is true for. And it's well known that relapse after detox is particularly dangerous. That's kind of a common story. As a patient presents to detox, they get their 7-day detox at Haymarket, and then they go out and they're still in that pattern. They go directly to their drug dealer, they use, and their tolerance is lower, and so then they have a severe overdose after they've been detoxed because we've done rid of their tolerance. So for those sorts of patients who we don't know if we can link with, or we think we might not be able to, again, if they're here for cellulitis or COPD, I think we can have a frank discussion with them and say, we can either detox you here with clonidine or with buprenorphine or whatever it is, or we can continue trying to link you with care. We can send you to Haymarket afterwards for detox if that's what you want, but we can treat your withdrawal symptoms with buprenorphine here, keep them under control, and we'll tackle discharge after that. And a lot of patients will say, yeah, focus on my COPD right now, focus on my cellulitis, let's deal with that, and then we can always work with linkage to care or linkage to detox. Or they'll, a lot of them will just end up going out and using again, and hopefully we'll get another shot at them to link them up with care in the future. But by treating their symptoms, I think we're able to treat their withdrawal symptoms to make the patient stay for their hospital stay, hopefully have less AMA discharges, so we actually deal with their medical problem. Our patient with osteomyelitis who keeps coming back and not receiving their course of antibiotics isn't served by a partial detox in the hospital and skipping their antibiotic prescriptions. So getting them through a course of treatment is important. We can control their pain, like I said, with the buprenorphine without massive amounts of full agonists. We can avoid kind of these complications with using methadone or something else for detox. And then we can refer these patients to treatment. We have a clinic now that's accepting patients. Like I said, I'm a medical toxicologist, so I'm avoiding some of the psych-related referral issues. A lot of patients, Medicaid doesn't cover psych treatment. I'm providing medication-assisted treatment, medical treatment for the patients, so we're able to kind of link some more of those patients up with care and see them in our clinic. And so hopefully it'll be more and more an option for our patients. But so if we want to do an inpatient induction, kind of start patients on Suboxone while they're in the hospital, Here's how we should do it. So we'll get into it later. So it's wait until the patient's ready. In the meantime, we're treating them with adjuncts. We're giving them clonidine, hydroxyzine. This is what our COWS protocol is for. These adjuncts, kind of keeping them comfortable until we're ready to start buprenorphine. Or we can use it for full detox, just to detox them on the COWS protocol if that's what they want. But start the COWS protocol, treat with adjuncts, and wait till they're ready. And then once they're ready, the easy button is just to give the buprenorphine via the withdrawal protocols. Order the buprenorphine as it's part of the withdrawal protocol. And they'll get 2 to 4 milligrams depending on their COWS score. It's not ideal because it's always requiring that they be in a bit of withdrawal to get a dose of the medication, but it'll certainly ease their symptoms until, on Sunday night, until we see the patient on Monday, that sort of thing. So it's certainly something that you could do for a patient. Let us fine tune it as we see them. And if you see a patient, they've gotten 8 milligrams of buprenorphine off of the COWS protocol, and they're like, yeah, I'm feeling a little better, but I could still use some more. You can always write them for an additional 4 on top of that if you want. Or if you want to just leave it as part of the withdrawal protocol, you could do that as well. What I would recommend and what I'll typically do for the patients is, again, wait till they're in adequate withdrawal, wait till they're ready, treat them with the COWS protocol. And then I usually, depending on what they're using and how bad their withdrawal is, if they're vomiting everywhere, they have a COWS score of 20, then you can give them 4 milligrams right off the bat. If they're kind of hanging out at a score of 10 or something like that, you might start them off with 2. So just depending how confident you are, how ready you feel they are, you can give them 2 to 4 milligrams of buprenorphine, and then again, same thing, depending on their result, give them 4 to 8 after that. And usually that's a good dose, based on a first day, is get them, around 12 milligrams for most of our patients. Obviously, we get some of those outliers who require more. And you can divide those doses by 2 hours to get an effect. They'll have an effect for sure by an hour. They'll be at maximal effect by 2 hours. So if you want to wait 2 hours between kind of dosing, and again, you can titrate it up because of this ceiling effect. As long as they tolerate that 4 or 8 milligrams, they'll be fine with up titrating it from there. And then, like I said, usually they end up on a dose for a substance use disorder between 8 and 24 milligrams daily. And we frequently split it twice a day. It kind of can help with pain a little if they're having it, helps with mood stabilization, helps with anxiety while we're in the hospital. Sometimes patients, like I said, we do daily dosing for the patients who prefer that as well. But usually it ends up being split twice daily, and that lets us titrate it a little easier too. So when is the patient ready? How do we make that decision? Because that's what we're worried about. We don't want this precipitated withdrawal. And so, your guys' role is partially to determine is the patient medically stable. They have to be able to tolerate that bit of withdrawal. And so if they can't tolerate the bit of withdrawal, then maybe we should use methadone or treat their pain with some other full agonist or whatever it might be to kind of prevent that. But if the patient's medically stable to have some degree of withdrawal, and then they have to have no or just very remote long-acting drug use. So if they are popping pills of OxyContin or using methadone, should probably get some help with doing the induction, particularly methadone. We want to wait usually 3 days after their last methadone if they're down at a low dose. And if they're up getting like 100 of methadone, and some people are using it on the street. So usually, if someone's in a methadone treatment program, we just continue it, and so that's no problem. But anyway, you should get help if they're using long-acting drugs. And then we're looking for mild to moderate withdrawal severity and 12 to 24 hours since their last use. And usually I say some combination. If it's been 24 hours since their last heroin use, and they seem mild withdrawal, but you're confident, you've asked them you're not using in the hospital, right? You can give them the Suboxone. If it's been 12 hours, but they're clearly in moderate withdrawal, they got rhinorrhea, they got big dilated pupils, they're sweaty, they're vomiting everywhere, then they're fine to start the buprenorphine. And we're using the COWS scale here, and the nurses are doing it primarily, but you can look it up on MedCalc and do it yourself as well. And I kind of separated it this way because there's some objective findings of the COWS scale, their pulse, their degree of diaphoresis. If they're like patients who are really in withdrawal, you'll see them, they're just yawning throughout the interview with you. They've got clear rhinorrhea, lacrimation, big dilated pupils, and these more kind of subjective findings. I feel like tremor. A lot of our patients, you ask them how they're doing, and suddenly they develop a tremor. The goose flesh, I guess, is probably a little bit more of an objective, but restlessness, anxiety, those are more subjective. And so, like, if the patient's like eating a ton of breakfast and complaining of severe anxiety and looks like totally fine, they're not in significant withdrawal. Whereas if they've got dilated pupils, they haven't touched their breakfast, or they're vomiting, then you definitely know that they're in some degree of withdrawal. So again, to give it a little on the earlier end, I like to see those objective signs of withdrawal for the patients. Whereas if we're out at 24 hours, most patients, as long as they're not having long-acting opioid use, are fine. And so just like a couple of things, make sure the patient's agreeable. They need to know what they're getting into. I would discuss their past Suboxone use. A lot of patients are like, no, Suboxone makes me sick. And you can explain to them, that's probably the precipitated withdrawal. You probably used it right after you used heroin. You weren't in enough withdrawal. A lot of patients buy it on the street to deal with withdrawal as well. Instead of doing their $100 a day heroin habit, they instead, spend the money to buy the Suboxone and go through the day that way. As I said, you want to wait 12 to 24 hours, confirm no long-acting drug use, and I always warn the patients of precipitated withdrawal. If they don't know about it, say, listen, this is going to make your withdrawal worse. If you're lying to me and you've been using heroin in the hospital, or really you used right before you came in, but you said it was a day ago, like, you're going to get sick. So, let's have an honest conversation. And then just make sure the patient knows how to take it. I always try and explain that sublingual dosing to them. So that way, after they've gotten 8 milligrams, they're not like, oh, I've just been swallowing it. Well, that's why you're not getting any better from it. So like I said, the really kind of easy button to use in the hospital is make sure there's no long-acting opioid use. Make sure the last use was 24 hours or longer ago and they can be in mild withdrawal. Or if the last use was greater than 12 hours and they're in moderate withdrawal, and you just tell them how to use it and you can start the Suboxone. So you're worried about the long-acting drugs, you're worrying about their degree of withdrawal to avoid precipitated withdrawal, and you can start it in the hospital for them that way. If you do run into precipitated withdrawal, it's just more of those COWS medications. I'd probably stop giving them the buprenorphine and treat them with more clonidine, kind of up their doses of those sorts of things, and wait till it resolves. And then you could resume induction if they're agreeable. But just treat it with the same stuff you would on the COWS protocol. A couple of tips for using with pain. If patients are on it, I try not to stop their home Suboxone. They have a baseline opioid requirement. And if we take that away, they're going to need massive amounts of full agonists. So keep the home Suboxone on. You can always split it more like we talked about. If someone's on 40 of home methadone, sometimes we switch them to 10 QID instead to switch them to pain. Same thing for buprenorphine. If they're on 24 at home, you can switch them to 8 TID, and sometimes that'll be enough for their pain. And you can always increase the dose, treat with NSAIDs, obviously, give them 1 PRN dose, that sort of thing. There is IV buprenorphine, so if someone, say, needs an abscess drained, they're here with cellulitis, but there's an abscess they need drained, surgery's coming to drain their abscess, give them a dose of 300 micrograms or 0.3 milligrams of buprenorphine beforehand, as well as some Toradol or whatever, and that'll ease the procedure along with local anesthetics and all that. And if needed, you always can overcome the buprenorphine with high doses of Dilaudid and fentanyl to help the patients with their pain. So just to summarize, it's an atypical opioid. Remember, it's this high affinity partial agonist that'll help you remember the ceiling effect, the precipitated withdrawal we'll get from it. It's useful for short-term treatment of withdrawal. It's useful for linkage to treatment to get the patients into treatment. And it can be used for pain. Make sure there's no long-acting drug use. Make sure it's been at least 12 hours. A COWS around 10 to 12 is good. That's that mild to moderate range withdrawal. And then discuss the sublingual use and order it. So I was just going to go over a couple of kind of just case examples if you guys are interested, or if you have any questions, I'm happy to answer those now since we're running towards the end here. Yeah, I'll just go over them and you guys can pipe in if you have anything.
We used to not be able to provide Suboxone at discharge, right? Is that changed now? Because I remember we used to have run into this issue where we didn't have anybody who would provide a prescription for Suboxone as a discharge. So we were say trying to link to some sort of treatment program.
We're linking to a prescriber. Or are we sending them with like a Suboxone?
So what I'd say is it depends on the patient. So If the patient needs a prescription, usually somebody from the suit team will be able to prescribe
We
it.
have that capability.
Yeah, we'll be able to prescribe it, right. So the suit team is always, exactly, if they need a linkage to treatment, if they have an appointment in 3 days, we'll be able to be the prescriber for it. And again, if it's a patient who needs their medical issue addressed and they know that you haven't yet linked them with treatment, but they just want to have their withdrawal treated, and then again, they can always be referred to Haymarket for detox if that's as good as we can get for them. That's always an option, so they can be linked with there without a prescription.
There's a little plug for medical students at Haymarket.
Yeah.
Doing histories and physicals on them. If anyone wants to talk to a medical student and see them on the back end,
Yeah.
they're lovely.
So I mean, one case that we might see is, a patient who's admitted for withdrawal. They're unable to tolerate PO, they stopped using heroin, they're vomiting in the ER, they get admitted to the OBS unit because they weren't able to be tuned up in the ED. And so now they're admitted to OBS, and they've tried Clonidine, they've tried Haldol, they've tried all this stuff, and they're vomiting all over the place. A dose of buprenorphine, that patient is clearly ready for buprenorphine. And so you could just order the COWS protocol with the buprenorphine and let the patient ride overnight, and then the suit team will see him in the morning, and they'll have already gotten a couple of doses of buprenorphine. They'll help us find their dose, and we can say, well, you're not vomiting anymore, we can't see you in clinic, let's get you to Haymarket for detox, let's get you to this treatment program, or we can see you in clinic. Let me write you a prescription, we'll see you, next Tuesday or whatever.
Now, putting your ER hat on.
Yeah.
Could this person just be treated with the
Yes.
same in the ER?
Yeah, exactly. So I'm working on that
Yeah.
too. It's an ongoing project too. But if they end up in OBS,
Yeah.
it's always good. And like sometimes, they say, well, though the patient, that I probably would worry more about kind of linkage to treatment there, even though they can do the same thing as they go to Haymarket, but they might not know if the patient's there overnight. They could easily ED OBS and then call us in the morning to see if they can, or have the social worker. I mean, that's what we're going to work on, is having the social workers in the ED knowledgeable about who can be seen in our clinic, and then they can make an appointment or message us to make them an appointment the next day, sort of thing, if a patient's discharged. But then the other problem is, again, linkage with the prescription. So we'd be able to provide the prescription. If we can get some ED docs to be X-waivered to be able to write the prescription even for 2 days, that'll be good enough, but they would have to stay for us to be able to see them to write the prescription.
I have a question about
Yeah.
the part of your presentation.
Yeah.
Off topic, but you showed that graph that 7, 2 weeks, 3 weeks of narcotic prescription.
Yeah.
The first one, there's X%.
Yeah.
They'll still become addicted, or at least still beyond that.
Yeah, that they'll be on it. They'll be reving prescription for opioids in 3 years.
Well, I think a lot of patients will get hospital for the first time of probably less than a week, I would assume.
Yeah.
I've never seen data about it anecdotally. So should we just stop doing that? Or is there data that might be okay? Is there some break points?
Well, I mean, I know there's a recent JAMA study saying that some non-narcotic pain medication is equivalent for pain control. So I think, ideally, and obviously everyone's strapped for time, we're having conversations with our patients. This is a habit-forming medication. I want you to throw it out if you don't use it in the next couple of days, because that way you're not giving it to your friend who then is going to get addicted to it. And I think we should try some non-narcotic pain medications on you first and see how they work, and hopefully not have to send you out with a prescription. That's in an ideal world where you have time to talk with them and patients are being reasonable and all this other stuff. I think the low-hanging fruit is the patients who, are, say, having minor surgical procedures and getting a 30-day prescription for their hand surgery, that sort of thing, is some of the lower-hanging fruit for us.
I think our population are usually not, it's not necessarily from procedures. And the surgery,
right.
They have great protocols. A lot of our patients, it's like you said, an element of chronic, but then also they probably can't take NSAIDs.
Sure.
And they'll tell me tramadol doesn't work. And
Yeah.
so you do sort of limit it. And so,
Sure.
unfortunately, some of the conversation is, if you don't give me this, I'm just going to keep coming back. And any of your companies say, then I guess you're assuming you did it, but
Yeah, right.
I'm not going to give you unreasonable amount of narcotics, but.
Yeah.
Is there? So I guess what I'm asking is there a field you consider the patient where I can tell them everything you just said, is there also a way to say I can't give you beyond this many days without putting you at more risk?
Sure. I think, again, that's something we're kind of working on, is kind of like some opioid prescription protocols, but I think there'll be less, certainly in the ER, we were going to try and start applying them, and while allowing providers, freedom to prescribe what they think is appropriate, but you're being able to point to that sort of thing. Our policy is to prescribe a 3-day prescription on discharge. I think just to have something to say this is what we do here, I think to kind of be able to externalize the decision-making process. A lot of times you come up to debate, where they have this is you could say, well, they won't let me do this. Who's they? Nobody knows. But like, and they would let you. You can write what you want. You're a prescriber. But to be able to say, this is what we do here. We write a 3-day prescription. So I think those sort of like discharge protocols would be helpful for that sort of thing. But otherwise, it is just a tough conversation. They don't have an answer to it.
The slides, you had 2 slides. One,
Yeah.
you said start the house protocol.
Yeah.
Once they meet the criteria. The next slides had a dose and then a dose 1 to 2 hours
Yeah.
later. Is that what we would be doing when we're starting the house protocol, or is that what the soup team would be doing?
So you
Yeah.
could choose to do it, either way. Like, this is the way that I said is administer the buprenorphine via that COWS protocol. There's 2 click boxes, one for a 2 milligram, one for a 4 milligram
Yeah.
dose via the COWS protocol.
Yeah.
And you can just click those, and the nurse will check the COWS protocol, and they'll administer them
Yeah.
based on that. Otherwise, if you want to be a little more hands-on,
Okay.
and again, you don't want to click those buttons until they're in severe enough withdrawal, because the COWS protocol is really kind of geared towards, being able to titrate the dose or kind of like detox somebody. So you could write them for the COWS protocol, and they would get it when their COWS is like 6, and if it's only been 6 hours since their heroin use or something, it's not meant to just set and forget it. So you still have to wait for until they're ready to order the buprenorphine off of the COWS protocol. And so, you'd order the rest of the adjuncts, then you'd add on the buprenorphine from the COWS protocol, or you could be more hands-on and again say, I'm going to order 4 milligrams now, they're in enough withdrawal, I'm going to check on them in 2 hours and give them another 8, instead of just kind of setting it and forget it. I think that it's a little bit better because you get them on that good dose of 12 milligrams early on and not just kind of make them go into withdrawal worsening. Once they're tolerating the buprenorphine, I think it's ideal to titrate it up until they're not in withdrawal anymore, or in minimal withdrawal. You know what I mean? Instead of waiting for them to kind of get worse and then giving them more. I think it's better to be able to kind of give them that dose up front, but it's easier to just say, okay, they're in bad enough withdrawal, let me just click the order boxes. And so it depends how involved, how much time you have, how confident you are in deciding, should I give 4 or 8 next, or should I just let the nurse decide based on the COWS protocol?
Any restrictions on giving cigars on pharmacy doesn't call it, like you can't administer this?
They shouldn't. So we fixed that in, I don't know, this fall or summer. We changed. There was some restriction on it, which we showed the regulations. We're like, okay, yeah, that's true. Anyone can write it in the hospital. So they shouldn't be, calling you to ask you about it.
Can I ask you about
Yeah.
a patient that I see over at Frown?
Yeah.
Which is the homeless shelter, and so this guy has, I think he uses quite significant amounts of heroin,
Mm-hmm.
and so he wants to get off of it,
Sure.
and he doesn't know how to, because if he stops for a day, he starts
Yeah.
to go into withdrawal. So I always tell him, just go to the ER, they'll manage your withdrawal, they'll get you hooked up with people. And
Yeah.
he says when he goes, I guess he's not getting the buprenorphine, but
Right.
he says he goes, he's off for 12 hours, then he gets sent home with information about where
Yeah,
to go
right.
next, and he's told that he needs to be off for 48 hours before he'll start
Sure.
anything, and he can't stay off anything for 48 hours. And
Yeah.
so he's in this cycle where
Sure.
I feel like I'm not helping him, because every time he comes to me with this desperation of wanting to get off, I'm just like, yeah, he's like, well, I do, but I'm back. And I'm
Yeah. And I mean, unfortunately, I think that's
How
the
can
same
I
kind of
empower
cycle that the patients end up with when they go to detox. Even if they were, if you were referred into Haymarket, it might be a little more prolonged process. That instead of being out in 12 hours, you'd be out in 5 days or something. But still, are like the ability to hook up patients with kind of poor, resources is still fairly low at this point. So unfortunately, right now, I don't have a great answer for you. We were just this week, we were at the emergency department innovations meeting, and we're trying to expand the whole service to the ER. And once that happens, we'll be able to see patients, if RUH takes their Medicaid, or uninsured patients, because we have some grant funding. So once that's up and running, if a patient presents to the ER and withdrawal, the hope is that they'll put, if they don't have an X-ray or whatever, they'll put the patient in ED obs, and then we'll come see them and start them on buprenorphine, or at least get our social workers involved with them with some more detailed kind of stuff for them. But unfortunately, we're not there yet, and so I guess probably instead of going to the ER, I would at least give them a shot at going to a treatment program, going to somewhere like Haymarket. The reason I always say Haymarket is because they don't really max out their detox beds. They're willing to take people for detox, which is not ideal. Again, I've said everyone relapses if they do detox, just like your patient, but like at least they'll be seen there and have a chance at getting linked to care, and then will get treated. Whereas like you could show up at Lakeshore and they'll just say there's no beds, go to an ER. So it would probably be better if he's not like acutely withdrawing and super sick to send him to somewhere like Haymarket. If his real goal is to get off of it, they would be able to do like an actual detox. But the linkage to ongoing treatment is still a problem that we're doing our best to help with.
So
That's the challenge.
Rush ER, no medical problems except that they want to detox, they'll need to send them 12 hours.
I mean, it all depends, Yeah, it depends the severity, it's like if they're unable to tolerate PO like this patient, they say they're at risk for dehydration or, whatever, they have other medical problems, they need to take their meds and, and they're vomiting them up, then we would probably keep them, we'd obs them for antiemetics and stuff. I personally would, write them for buprenorphine if I were working an ER shift, and try and link them. But again, if there's nowhere to link them with, then I'd be in trouble as well, and so to give somebody a single dose of buprenorphine and then discharge from the ER, not in bad withdrawal anymore, isn't much of a solution for them either. But what I might do is I would give them, the buprenorphine and tell them then to go to Haymarket. If you send someone who's like vomiting all over the place to Haymarket, they're going to send them back and say they're not medically, they're not stable for detox at this point. Like they need to be able to stay on top of it there, and that's why we get patients from Haymarket. But anyway, but for the most part, if a patient has mild withdrawal and you're able to give them some Zofran, and they're able to drink a cup of juice, we'll give them that flyer of resources that the social workers will provide them and get them going. Because we don't have much else. Again, they're working on kind of a similar model where they'll try and start them on buprenorphine in the ER. Like I know some of the ER docs and toxicologists there are X-waivered, and they're kind of working on rolling that out as well and linking them with the MAT clinic there.
So if you can control symptoms of mild withdrawal with other medications,
Yeah.
whatever Zofran, and you give them that sheet,
Yeah.
like they would be accepted into Haymarket if they went there.
Yeah, exactly.
Yeah.
Yeah, and they could go there and again, I'm not totally certain on their intake process. What qualifies for treatment. But if you qualify, they'll accept them in there, and it's not like insurance based. It's just like if their substance use disorder is severe enough and they need treatment, detox, then they're in there. So yeah.
Thank you so
Yeah,
much
no
for
problem.
coming, really. This is great.
Yeah.